Hello and welcome, guys. This is Rick Mikado. We're coming to you with the December issue of Risk Management Monthly. Kevin Clower and Jen Snackus are on the line, and we're going to do all cases this month. And we're going to start off with some cases that really applied to what we talked about last month. It was largely about the issue about, abortion and EMTALA and state laws and the interchange and tension between those three issues. And we went through a fair amount of the legal aspect. Now we're going to go through some specific cases that bring out the problems that are popping up. And these are only a couple cases that we're going to talk about that are in Texas, but they're similar cases have been reported in Georgia and a bunch of other states that where there's a conflict between EMTALA and the state law, and the question about which one prevails. So let's begin. Okay, the first case. This was in ProPublica, which is a nonprofit investigatory publication, and it was in their November 1st issue. And this is about a 18-year-old female who initially went to the ED and was diagnosed with a strep throat. It was the day of her baby shower, and on awakening that day, she had a headache, and in the afternoon, she started vomiting and running a fever. So she went to the shower, attended the shower, and thereafter, mom and the patient went to the hospital, where they waited for catches 4 hours. And I know some of you are going to say, 4 hours? They got in really quick, based on what's going on at our hospital. But 4 hours is an embarrassment. And if you're longer than 4 hours, it's very embarrassing. Anyway, the nurse gave her a plastic pan in which to vomit while in the waiting room. I took my grandson to a hospital in Norfolk, and the waiting room was circular. So everybody was sitting around the walls of this waiting room. It wasn't like in rows. So when you have a circular waiting room like that, everybody gets to see everybody else. And they gave this one patient who came in who was really looking pretty nasty. They gave him a bag to vomit in. So this guy's vomiting in this bag in front of about 20 other people. And I said, is this what it's come to? But the answer basically was yes. But anyway, she went to the urgent care center, was seen by a nurse practitioner. A strep test was ordered, and it was positive. And as a result, she was given antibiotics, and she was out the door. But on returning home, her abdominal pain, which was noted at the time, but was thought to be part of the strep throat process, was getting worse. And so at 3 a.m., the patient was quoted by her mom as saying, Mom, I'm in a lot of abdominal pain here. So she arrived at a second emergency department where she was screened positive for sepsis. At 4:20 in the morning, an OBGYN noted a temperature of 102.8 and an abnormally high pulse rate. Now we're talking about, is this a strep throat? After 2 hours of IV fluids, one dose of antibiotics, and some Tylenol, the patient's fever didn't go down, her pulse remained high, and the fetal heart rate was abnormally fast, medical records showed. Some people believe that if you have a fever, and if we give Tylenol or Advil or the like, and your temperature doesn't come down, that indicates that you have a serious disease, and that if it does come down, it doesn't, which is absolutely 100% untrue. It can go either way. So their reliance on what the temperature was going to do here was ill-founded in the first place. So the OBGYN said, okay, the patient has a strep and a urinary tract infection. Now I don't know where that came up from, because there weren't a lot of details in the article that I read. He wrote up a prescription and discharged her, but she was so weak that she was wheeled out of the emergency department. You know what I've said about people who walk in and were wheeled out? You better be real careful. Her mom noted her daughter was hunched over when they left in pain, breathing heavily and pale in the face. 9 o'clock the next morning, the patient went back to the same ER that the OBGYN had seen her in after the patient passed some blood at home. So a second OB saw her on her return visit at 9:30 in the morning, and based on a bedside ultrasound, could not detect fetal heartbeats. Fluids and antibiotics were given. Prior to admission, a second ultrasound was requested, this time with documentation and confirmation of the absence of a fetal heartbeat, as required by Texas law. The second ultrasound was performed 2 hours after her arrival, and she wound up in the ICU, now in critical condition, and then she vomited black blood, and it came through her nose as well. I think all of us in our career have seen people who have this thing where this black stuff comes up through their mouth and nose. Generally, not a good sign at all. So this is an example of DIC, and this patient died as a result. Oddly enough, no lawyers have agreed to accept the case because of the high willful and wanton standard in Texas. So you have to basically be an axe murderer in the state of Texas to get accused of malpractice because of the willful and wanton criteria that was put in there supposedly to protect doctors, but it doesn't really help patients very much. In any case, that was the standard that applied. The patient is at least one of the 2 deaths reported in Texas as a result of a miscarriage that was mishandled and delayed in care, and sepsis developed, and the patient died.
Though, what the thing that I would say about that is you could characterize it that way, but I don't think that it would be fair to, especially early on in this case. I think that there was just a clear malpractice in the first instance. So you find a strep pharyngitis, okay, that's you're a nurse practitioner. You think, okay, everything is related to this. I've read that you can have some abdominal pain with this and that sort of thing. The problem is that this is a pregnant patient and you need to do a little bit more, or a lot more. You need to, I don't see any vital signs here. I don't know if there was fetal distress. We don't know that from this case, but those are things that should have been evaluated, certainly.
Yeah, I agree. And I don't know, Rick, maybe you know the gestational age of the fetus, but I do think, I mean, they said that the patient's heart rate was abnormally high and didn't respond to antipyretics and fluids, and nor did the fetal heart rate go down. Well, to Jen's point, maybe there is fetal distress. Maybe you need to do more. And what's fascinating to me is a sepsis screen, as overly sensitive as they are, might have identified somebody who was actually septic. The organism was appears to look at, I don't have all the facts, but it looks like the organism, because it was a common organism, led the clinician to believe, oh, then it's not sepsis. Last time I checked, strep can be pretty freaking bad. And you can become bacteremic with it and bad things can happen. She probably was septic during that first visit. And yet was discharged with a prescription, it sounds to be, because strep throat was the diagnosis. Well, strep can cause some pretty bad things if it decides to get out of control.
What about the carrier state? A substantial subset of people will have a positive strep when they don't have strep throat at all. And it was kind of like a sore throat was never kind of a prominent symptom in this patient at all. And, I don't know that adults vomit with a strep throat. Little kids might vomit, but I don't think adults do. And
well, you're right.
And especially in the setting of being pregnant, and it was acknowledged that the patient was having abdominal pain, which I guess was somehow kind of shined on for some reason. So I think the thread in this case is not so much malpractice, which I think is probably would likely be able to be proven in terms of the delay. But that's really the theme, is that the delay of care, because patients in Texas who are pregnant you don't want to have to kind of consider them as people. They don't want to deal with pregnant people, and I think that this. I think this was shown that the OBGYNs, despite the fact that this person met sepsis criteria, discharged the patient with a UTI. Yeah, right. You don't get two infections at once generally, but a UTI and a strep throat. Hardly. They had probably one or the other, or more likely neither, and was more likely that she had some sepsis related to her pregnancy.
So,
So.
Rick, I just here, I think that it is a stretch to say that multiple providers didn't want to deal with someone who's pregnant. I really do think that this is malpractice. I think that frequently patients come in, the provider wants to hang a diagnosis on there and doesn't look for other things. And then once that happens, then you start having anchoring bias, especially as things progress over a short period of time.
Yes.
And so, do I think that first, I do think that there was negligence at that first visit, at least on the surface. There aren't a lot of facts here, but
Right,
on the surface, it looks like negligence.
I agree.
And it would be a stretch to say that this person was negligent and just diagnosed her with strep pharyngitis and gave her an antibiotic because she was pregnant. She probably would have treated any other patient the same way. The problem is that with a pregnant patient, this is a high-risk patient. You need to take this sharp abdominal pain is not something that you can just blow off and say, oh, well, sometimes you get abdominal pain and strep pharyngitis.
Well, you can, but in kids, mesenteric adenitis, so maybe, but as Rick said, adults, but it's important though, she didn't have upper respiratory symptoms. You would expect an adult with strep throat. What are you seeing in the throat? And you'd expect to have some significant symptoms. I don't have a copy of the urinalysis. I don't know if either of you do, but if it truly was a UTI, it is sepsis. It's pyelonephritis with a fever. And this is a sick person. And to your point, Jennifer, you're pregnant with pyelo, that's an admission.
Exactly.
Yes, exactly. So here's an OBGYN. The patient has 102.8 fever, abnormally high pulse, and she's going home with these diagnoses of UTI and strep throat. Remember what Greg said? Greg used to say one of the biggest impediments to the correct diagnosis is a prior diagnosis. And this is another case where, they said I had a strep throat when I went to the urgent care. So that gets carried along, and this confirmation bias comes into play, where you get distracted. And the second doctor to see a person, you should be concerned when people come back. Always, the unscheduled return visits, which means that you need to look more carefully and more thoroughly at a patient. And if anything, the OBGYNs were even more negligent here. Who would send a 102.8 fever pregnant patient home? Who would do that?
Well, with an elevated heart rate, elevated fetal heart rate, and I'd say I'm gonna go with, here it is. Wait for it, you two. The square peg into the round hole phenomenon again. This is not strep throat. It's not strep throat.
Yeah, there are a couple of things. One of my mentors was the one who wrote the Sentinel article talking about abnormal vital signs in patients with bad outcomes, and the number one being elevated heart rate without an explanation, without a good explanation. You don't send that person home. You sure as hell don't send a person home who walked in and now is in so much distress that they need a wheelchair to get out. And then a pregnant person on top of that. This is just the fact that or not the fact, but the idea that no lawyer would take this case is just suggests to me that the lawyers there are not very smart, because this is a slam dunk case.
That's a bold statement there.
I guess because of the time in the emergency department, that this was, at least this article said, the willful and wanton criteria got in the way here. What's the name of the lower criteria for negligence? Is it ordinary negligence?
It's ordinary negligence. Uh-huh.
So this was extraordinary negligence. Okay,
Well,
so
maybe.
that's this is a kind of a good case, but the next case is the better case, and this is also a Texas case reported in a ProPublica. Kevin, why don't you tell us about this
I'll do
lady?
it. This is, I think it's Miss Barney, she was 28, 17 weeks pregnant, cramps and bleeding. So she went to the emergency department, and within 2 hours of arrival, she got an ultrasound. It confirmed bulging membranes with a fetal head in the cervical os. So, I mean, it makes sense what's going on here. The cervix was dilated to almost 9 centimeters. Amniotic fluid was decreased. We know what's going on. It was listed as miscarriage, quote unquote, in progress. I think I'm going to stop here for a second. I think some of this, as we talked about in the November issue, has to do with terminology. We have to look at non-viable pregnancies as non-viable and definitively state that. No one's going to perform an elective procedure, an abortion in this regard. But if this is a non-viable pregnancy, then it should be looked at differently. This is clearly non-viable. It is a miscarriage in progress. I think we need to be stronger with our terminology and make sure that we're noting that this is an inevitable miscarriage or abortion that can't be stopped, and we need to treat the patient.
Unfortunately, this child had this baby had a heartbeat, and one other thing, Kevin, she went initially to an ER with cramps and bleeding, and she was discharged, but returned the following day, and that's when they did this ultrasound, finding that cervix was 8.9 centimeters dilated, and amniotic fluid was decreased, and the radiologist said this miscarriage in progress was happening. But why don't you take us through this a little bit more, because this gets pretty outrageous.
Yeah, it really does. And again, if you looked at, let's say let's use a more significant example, anencephaly. Okay, there's still a heartbeat. There's no possible viability there. We need to frame these inevitable outcomes in the context of their inevitability. So people don't think that there's an elective decision being made that, we're performing an abortion in the classic terms that's against the statute. No, this pregnancy cannot survive. There is no way, and it's putting the mother's life at risk. So it's fascinating, if you go through this, that a fetal heartbeat was present, as you stated. And what's crazy is the OB who was taking care of the patient ordered repeat ultrasounds, it appears, to continue to watch for the heartbeat. And it was at 40 hours, no heartbeat was detected, and therefore they accelerated the delivery of the uterine contents via medication. So I assume that was Pitocin or something. I don't know.
Right.
I have all the details. Mm-hmm. But so why would you wait 40 hours to do what you know is right for a patient when the pregnancy is clearly non-viable? This is one of those things we talked about in November, where I think people are misinterpreting what the latitude they have, even within the constraints of these new laws, to take care of patients and place the mother's health primary. This is unfortunate.
It seems in this case the doctors prioritized the fetal heartbeat being not present and documented as such. You have to have, the picture of, a systole or something to that effect, which will support in the record your diagnosis that the heartbeat is not present.
Yeah, and I think even though you start the first day, okay, I get it. You're in the ED the first day. Maybe it was a standard type of visit where the pregnancy is at risk, but and it's a threatened miscarriage. You send that person home. He came back the next day, and all this is going on. And I think really the crux of this case is really the second visit. And right. Really just fascinating. 8 hours later, after expelling the contents of the uterus, a second OBGYN discharged the patient.
8 hours after being in the hospital for 40 hours, waiting for the
Yes,
heart to stop.
waiting for the heartbeat to stop.
All that time with an open cervix.
Absolutely. And then you can see how it transpires later. Then the patient called back in for advice. That's also an issue and a concern we can talk about in another issue of Risk Management Monthly, but giving phone advice just to reassure people when you don't know what's happened with the patient and you don't know their clinical status is fraught with difficulty. So they got reassurance. They didn't come in. And finally, a couple days later, they came back in. And because of some COVID restrictions and childcare issues at home, that was the last time that her significant other saw her because she died of sepsis in the hospital. This was his wife. I don't know how long they were married, but it's just an unconscionable loss. And the delay is certainly due to the legislation, but also because I don't think the clinicians felt empowered and comfortable enough to do what they would normally do, what the standard of care would be in this case, because of the legislative initiatives that are in place. But as we talked about in November, there was probably a carve out here where the OBGYNs could do what they would normally do because this was a non-viable pregnancy and a sick mom.
Yeah, I think, the fix is going to be legislating this, unfortunately, or at least having an understanding within your hospital group policies, whatever. And I agree with you. There's a huge difference between an elective procedure and a pregnancy that's non-viable that requires emergency care.
And I think that distinction needs to be, as you said, Jen, perhaps legislated, but it could be written into the rule writing component. This could be in the regulatory language. We don't need to go back to state legislation to write a new law about it, but we need to clarify what this law means and help clinicians to be able to do what they know is right for patients. If this is not a choice about whether the pregnancy will continue or not, this is a non-viable pregnancy, why in the world would a state suggest that a clinician should place the mother's health at risk? I don't think they are, but I think the clinicians are interpreting that the states are limiting their ability to do so. We need to bridge the gap in communication here.
Well, certainly some providers are feeling confused. We know that from the cases. I would never want to, I won't assume that providers are making, are just being blasé about the woman's health. I think that they're unsure, that they're scared, that they're delaying, and it's in at least some cases causing a problem.
Well, and I didn't state, and I don't think I implied that clinicians are blasé with it. I think they're stuck. They don't know what to do. So they're going to keep monitoring until they think they can intervene, where actually I think they could have intervened. They wanted to do the right thing.
Right.
And I think they're really they're really focused on it. But I think if there is still confusion in the clinician community, it doesn't matter what the statute says. It doesn't matter what the regulatory language says. The clinician community, the clinical community is not comfortable with what you're telling them to do. We've got to clarify. And it may be quicker to do it in regulatory language than it would be with a new legislative approach.
The other thing that's kind of an aside in this case, which is really tragic, is the number of patients who were brought to the emergency department during the COVID time when they excluded any family, where in fact they dropped them off in the ER, and that was the last they ever saw them again alive. How many patients do you know when that occurred? And it's just heartbreaking that had to have happened. And this was one of those cases.
Well, we need to learn from these cases, that's for sure, Rick. From the COVID standpoint and how family members who are going to lose someone, who have a critically ill family member, can be with them. And I think those policies evolved over time, and I think that there was some flexibility then created around that. And but these cases and these losses need to inform us about how we can do a better job, and whether that is going back to legislative bodies or agencies to write better regulatory rules, or just clarifying what should happen. This needs to happen because clearly the kind of care that people would expect to receive isn't occurring in some cases because of this new phenomena. We've got to fix it.
So we talked about the court system trying to clarify EMTALA from state laws, and although I think you would probably agree that we initially assumed that EMTALA trumped everything. That in fact that was the law of the land. That was what applied. Your state can do anything that you want to make it more strict than EMTALA, but you can't make it any less than strict than EMTALA. And so we get into this issue of these cases being brought to the Supreme Court, saying, "Listen, straighten this stuff out here, because this EMTALA thing is kind of a problem for us in conjunction with state laws." And so it was thought that the Supreme Court would handle this. Well, the Supreme Court went into session in October 7th, just about a month and a half ago, and they decided that they were not going to take on any of these EMTALA / local state abortion regulations, and decided that the lower states would they'd have to be handled at that level. And so because of that, the Texas law prevails, because the Texas has basically said, well, we don't believe in EMTALA here for this particular situation. And I'm not sure why the Supreme Court didn't want to take this on, but because so many people are kind of caught in this gray zone. The patients are caught, the doctors are caught. In any case, I think it's a situation that is really sad that it has not been resolved, because there's a bunch of states that are involved in this now, and more patients are being involved. These were just two examples.
No,
So,
you're
Rick-
right, Rick. Oh, go ahead, Jen.
Well, what I was going to say is the reason is that it's not that the Supreme Court doesn't care. The argument, and what the argument has been from the beginning, and even Ruth Bader Ginsburg argued that the original laws were not based on proper constitutional arguments. The argument is that this should never have been a constitutional issue brought by the Supreme Court, and that this was a state issue. And so it may be not an issue of, why isn't the Supreme Court interested in it? It's that the court has ruled that this is a state issue, and it'll be up to the higher courts within each state to decide how are these laws going to interplay. And
Well, here's the issue that I have with their decision, or their at least interim decision not to look at this. And let's talk about preemption for just a minute. If the federal government decides to legislate in a certain area, let's say it's, let's just say it's interstate commerce. Well, then a state can't legislate in the same area unless it uses the federal legislation as the minimum standard. The challenge here is EMTALA and the state statutes regarding reproductive care are not the same in scope. So you've got EMTALA that's saying everyone needs to be seen regardless of the ability to pay, and you need to stabilize any identified emergency medical condition through a medical screening examination, which includes stabilization. Now, with the Dobbs decision, the government has said this is not, the federal government has decided specifically and expressly to not legislate reproductive care. That will be given to the states. So the states are now solely in charge of reproductive care. And then you've got EMTALA, which is certainly a federal legislative act since 1984, but it's not ruling in reproductive care. But reproductive care, when it does result in somebody's decompensation, these two lines cross. We need that clarified. If people's obligation, if the hospital and the clinician's obligation to stabilize an identified emergency medical condition could be established by the Supreme Court, that this takes priority over any state reproductive law, then it would clarify it. And the Supreme Court elected not to take on that question, in my opinion. Now, certainly dismiss what I said if people don't agree with me, but that's the way I see it. So preemption doesn't completely cover this because states aren't ruling on EMTALA. They're ruling on reproductive rights. that happened to cross over into EMTALA, and we need a clarification on that.
So one thing that I would argue is first of all, I agree. If there are that many people questioning this, you're right. There has to be clarification, and there certainly are a lot of people questioning it. What I would say is that the definition of EMTALA and what EMTALA care is and requires captures all sorts of things. Like the state may regulate this type of care or that type of care. It doesn't matter. An emergency condition is an emergency condition. Stabilization is stabilization, regardless of any of anything else. I think one of the problems is that, and this is just goes right along with the last case, is that we're talking about people are getting really confused about what the intent, I think, is, I hope, and that is putting limits on ages, the age that someone can have an abortion. Another problem is that it varies widely from state to state when there are limitations placed. If you look at Europe has a lot more restrictions than a lot of our states do. Most countries around the world have some sort of limitation. That's not even the issue, though. The issue is
Right.
that what we're talking about is what I believe a lot of the laws are limitations on elective procedures to terminate a pregnancy. I personally would not have any angst treating a patient in any state, no matter how restrictive their laws were. If I have a patient who comes in who is unstable, who requires emergency care, I don't believe that I would be in legal jeopardy by treating that patient. And I don't think that any of our listeners should be afraid of that either. Are there going to be cases that are brought potentially? Maybe. But I feel confident that when things shake out, that's how they'll shake out.
Well, Jen, I agree. And if we can also say, hey, this is a non-viable pregnancy, not by my choice, not by the mother's choice, based on the medical facts. No one's making a decision to terminate a pregnancy. The pregnancy is in the process of self-termination here. That's not it's not a medical term, but that's exactly what's happened. What I'm worried about with the Supreme Court, and I'm glad you brought this up, Rick, and I'm glad you added it to the agenda today, is instead of saying we're just going to give you absolute clarity on this, they're going to let case law decide this. And to Rick's point earlier, if there's a chilling effect now on attorneys wanting to take on these cases, we're not going to get the case law that ultimately clarifies how EMTALA interplays with the state reproductive rights statutes. So the Supreme Court, they could do us all a favor by saying, hey, if it's an emergency medical condition, to your point earlier, Jen, you've got to stabilize it no matter what. That's been the law of the land since 1984. That hasn't changed. And once you've done it, you've stabilized every EMC, emergency medical condition that's been identified. Well, now you can take a look at this reproductive right issue at the state. If they said that, it would end the debate. And they, come on, they could do this. They could do us a solid.
I agree. I think that's a really good point, and really well stated.
Thank you.
You're welcome, Ken.
Well,
do not call me Ken Milne again. I love the man, but he lives too far away from me to get us confused.
It's we don't certainly want to talk any politics on this thing, but the Supreme Court
Don't do it.
free. And so you can maybe see their reluctance to deal with this. Okay, so let's do the last case, Jen, related to abortion, pregnancy, and in this case, Catholic hospital policy.
Yeah, this is an interesting case, and the sources on these are the October issue of Becker's Hospital Review and a New York Times article from September 30th. And this case relates to a story about the California Attorney General suing a Catholic hospital after a woman was denied an emergency abortion, making this the first case of its kind in that state. So the case details a pregnant woman at 15 weeks with twins presented with ruptured membranes Um, and the standard treatment in such cases typically includes a DNC or DNE procedure or an induction of labor, because this is not this is not a viable pregnancy as we discussed. And as the condition carries really high risk, it carries a risk of hemorrhage, it carries a risk of ascending infection and sepsis. And again, the fetuses are not viable. The Catholic hospital declined to do this procedure because it was its policy to prohibit abortions unless the mother's life was in imminent risk. And again, I would argue that ultimately, without treatment, the woman's life could be in imminent risk. And we run into the same problem that we did in previous cases where there's still a detectable heartbeat. And this is where we really need to get clarification moving forward if we're going to have a chance to resolve these handling issues. So the outcome was that the patient's condition worsened. Her husband brought her to another hospital where she arrived hemorrhaging and passing large blood clots. One of the fetuses was expelled and the other required emergency surgical removal. A physician at the receiving hospital reported to them that this was not an isolated case and that she had treated other patients who had been denied abortion care under similar circumstances at this same Catholic affiliated hospital. So the Attorney General filed suit, citing failure to provide standard emergency care, which I would agree, and potential violations of state and federal healthcare laws, and that would be EMTALA. And so again, we are back to this issue of state law versus EMTALA and clinicians' confusion over what is meant in abortion. What is if a life is terminating, the life is terminating. You're not terminating it.
Right.
That's how I would view this.
Well, and I'm with you, Jen. If you take a look at it this way, if you're balancing the two lives, there is really a very careful balance and a very challenging decision to make. Once the pregnancy is not by choice and not by opinion, but by fact is non-viable. Why can we not shift 100% of our energies toward the mother's health, knowing that you even said, well, you know what, in this particular case, they didn't think that her life was eminently at risk at that point. Well, even if it's a little bit at risk, you can't save the babies anyway. Right. Even if she had a 0.5% chance of mortality, why don't we favor that if the pregnancies are truly non-viable and this process is inevitable?
The other thing that I would add to this that we haven't really even discussed, and that is the mental health aspect of this and mental health treatment and what this is doing to patients. So, this woman, I don't know if she's Catholic, if she's religious, she's going to this Catholic hospital. Let's just say for the sake of argument that she is, that she's conflicted by this as well. Instead of doing what's right and saying, telling her, look, the fetuses, I'm sorry, are not viable. Let's take care of you. Let's make sure that you are still in good health so you can try again, whatever. By doing this, we are not performing an abortion. This is a miscarriage. This is a non-viable pregnancy. And I think that especially for people who don't want an abortion, wouldn't have an elective abortion, this may be causing a lot of harm in that way as well.
Well, I agree. And I think maybe you just prompted this thought, so I want to thank you for that, Jen. But maybe what needs to be included in hospital policies and regulatory language as well, maybe even statutes, is the indication for the procedure. These are not called medically abortions. That's the colloquial term that is used. These are DNCs. They're wherever we're going to do. There is a medical term that we're using for this. The question is the indication. If it's elective by choice, that's what should be really governed under these laws. When we know I'm going back to it, it's a non-viable pregnancy without any chance to save the fetus. And even if there is a small risk to the mother, you've got to favor taking care of the mother. You're not balancing at all. You can't save the pregnancy. So the indication is because you need to facilitate what's happening and to protect the mother's health. So that's an appropriate indication to do the procedure, and we need not call it an abortion.
You know, I don't know. I can't guess what people's intentions are, but I would like to believe that even the most strict authors of these legislative initiatives are not considering and thinking about these cases. These are non-viable pregnancies. I can't wrap my head around the idea that this is what they're talking about. And
Well,
I
and
wish,
maybe it isn't, and we're sharing our thoughts and based on some narrow circumstances of some cases, and there may be some nuances or expansive consideration of this that we're not including this month, the three of us. So there's some limitation to our discussion here, but I hope it's going to promote and prompt some good, careful consideration of how we can apply the current circumstances and how we can make it better for people down the road. But it is as gray an area as at least I've encountered since I've been a physician, with lack of clarity for the people who are taking care of patients and doing their very, very best. And my heart goes out to everyone trying to do the right thing.
agreed.
You know, this Attorney General in California took this case because they have standing in that the California legislature created a law that is virtually the same as EMTALA. And what the California legislature has been doing has been creating its own laws that back up federal laws in the fear that federal laws may change, and they want to maintain, something like EMTALA, so they have their own version of EMTALA, and that's kind of was part of this article, which is really kind of interesting that this would occur now, because there's a bunch of Catholic hospitals in California, and I must admit I don't know what the policy is with regards to them. It would seem that they would follow EMTALA, but I'm not sure how this works. But in any case, let's get off that topic. I think we've brought up the issues. I don't know that we've solved anything, but we've brought up the issues. Okay, let's
It's a
move
good
on
conversation. Maybe it prompted more questions than answers. Of course, we don't have the answers, but I think at least if people feel supported, that there are people who are considering it.
We're
Yes.
mere conduits. All right, let's get into a couple of other cases that I thought were really interesting, and the common thread here is delay. A 3-year-old boy was brought to the pediatric emergency department for the third time in 2 weeks. He was pointing to his abdomen, lethargic, not eating, there's the L word, not eating or walking. He had recently had COVID and RSV. He got the double whammy. The department was described as chaotic and overwhelmed by the mother, and I think you can all visualize your department being chaotic and overwhelmed at least some of the time. According to his mom, that was her position. Getting a nurse or doctor to check on the boy as he continued to decline was a struggle, his mother recalled. Staff kept on commenting to the family about they were just how busy they were. So he was admitted to the hospital on paper. You see this ridiculous thing where you technically become admitted even though you're staying in the emergency department. And that relates to payment. It relates to, being admitted in the hospital before midnight, and you get another day's credit for being there before getting admitted before midnight. So in any case, he was admitted to the hospital on paper, but was boarded for over 6 hours. He died after being in the ED 17 hours. None of the specifics of the patient's care were noted in the story. That this is out of Albany, I believe, and basically the kid had a pulmonary embolism at post and an enlarged heart, maybe something left over from COVID, and Budd-Chiari syndrome. The families are not saying the patient was treated in a negligent manner. The CEO stated that ED backups can occur from larger numbers of patients. Okay, I got that. Increased acuity, all right, and staffing issues. All three of these are the triple whammy here of emergency department right now. I think it's probably worse now than it was when I was in the emergency department a few years back. We have not been able to solve this problem for a long time. The idea of we were holding patients 20 years ago, and this was something that obviously would eventually get cured up, cleared up and cured up, and didn't happen. Okay, so we got this kid who died a long time, staying in the emergency department. And one of the problems is that if you are one of in these states where the standard is willful and wanton, nobody's going to take care of the lawsuit for this case because of that standard. I call that the axe murderer standard. That was what was going on here. But technically, the patient was admitted. This is you've seen this at your hospital where this is a paperwork process where some nurse may come down and do what's called the initial assessment, fill out admitting paperwork. They ask you about all kinds of questions that are irrelevant to why you're there, like about your last bowel movement and all this other crap. And now you're technically admitted, even though you're still in the emergency department, even though if you deteriorate, you still need to respond. And it's like, well, technically, the admitting doctor is the pediatrician, Dr. So-and-so. These are all technicalities. And I find it very frustrating to say these are not emergency department patients. They're taken care of by emergency nurses, and the doctors who took care of them initially are going to be available if things go bad. But these patients often go into limbo where they're admitted, okay, they're not ours anymore. They're somebody else's.
There's got to be a plan, Rick. And just because you're admitted doesn't mean you're going to get the same care as somebody who's in a bed on the floor and admitted. And that's where some liability arises. I mean, you can't just say, hey, they're admitted, so they're not our responsibility. You can never get away from the geographic proximity argument. So where did they exist? This patient was in the emergency department. There is not one jury of laypersons that's ever going to say the emergency department didn't have responsibility. They're sitting right there.
Kevin, they were admitted. They just appeared to be in the emergency department. They were really up on the floor.
Well, and what I'd like to do, and it's not easy, but some progressive hospitals have said, all right, if we're over capacity and we're admitting patients and we don't have beds, but we are admitting them to non-traditional units, hallways, emergency departments, whatever else, how do we staff them? The emergency department staff can't care effectively for admitted patients. So you got to call people in, you got to borrow from the floor. If you're doing those things, then it's not the inconvenience of being in a hallway, it's being in a hallway and not getting the care that you deserve. You can get a patient complaint because you didn't get into a room. That's different than, okay, you're admitted, but because you're not upstairs and we don't have inpatient nurses here and the inpatient care team is upstairs, no one cared for you. No one is ever going to explain that way. You can't, I'm surprised that even the CEO statement that you quoted here was, well, it gets really busy. We get more patients, we've increased acuity. Well, yeah, that's, so many emergency departments in our nation. What is your solution, Mr. CEO? Because there are solutions.
Well, speaking of Dr. Milne, there was a recent, I don't know if you saw the ASAP Now article on the staffing issues in Canada. Did either of you see that?
Bad.
Yeah, so bad, right?
Real bad.
So when they don't have the staff, they just close, and there might be a written note on the front door. I mean, at least we don't do that, but we do have significant difficulties with this. I agree. So in our emergency department, if someone is admitted, they get orders. They continue to be cared for by the nurse taking care of that, that set of rooms. And you're right. If there's a significant decline in condition, the emergency physician is there to try to help stabilize. But it is not the same as being on the floor. It is not the same as being in close proximity to the pediatricians. It's not the same as having a PICU nurse. Yes, our emergency nurses are good, but they're not PICU nurses.
Yeah, and I agree with you. It's not the same, and we've got to make sure we have a plan to make sure patients do get, we can approximate that level of care while we're trying to get them moved upstairs. So all hospital leaders, including the CEO that that Rick quoted, it's like, well, yes, those things need to be stated as contributing factors as to why things happened. But here's what we do to do our very best to mitigate that. We can't mitigate every concern and risk to a patient. We can't. But these things happen. And when they happen, we call in more staff. We make sure that they're cared for by inpatient nurses. We make sure that the same policies for inpatients are carried out to the best of our ability in the emergency department when they're boarded. And that's what I was saying with my former comment, that you're going to state the reasons why this happens. You've got to state how you're trying to resolve it. There's some days you just can't provide the level of care that you want to. You've got to be able to explain that you've tried to do everything that you can. What I don't like about these cases, and it's all of them, is there has not been a true and well-defined transition of care. Who is the primary person responsible? Jen, you mentioned it. So if the emergency physician is available for a decompensation, that needs to be in policy. If the internist or the pediatrician, whoever's admitted this person, is not in the ED and there's a trend of, or there's a precipitous decompensation, you go to the emergency physician. You don't try and call the person who's on the floor. But also, if there is a trend of vital signs that don't look right or ongoing needs of the patient, you should be going to the admitting physician.
Right.
And in these cases, and in the one, if we want to pivot to it, the one that was in Syracuse.com, they didn't do either. 70-year-old lady in a hallway who had a known history of a valve replacement that was short of breath and not doing well, she got admitted and sat. The ED didn't appear to care for her well, and neither did the inpatient side. She sat until she decompensated. And it was just, it seems pretty horrific. And even the daughter's statement, which is, I'll give you the quote here. If my mother would have received the emergency care she needed upon her arrival to, and I won't mention the hospital's name, I believe she would still be alive. Well, we don't know for sure, but she has a pretty good argument because of everything that happened. I mean, there was no call button. There was no attention given to the patient. They didn't switch the oxygen tanks. They forgot to feed her. They didn't give her a meal. I mean, this case is done. It never sees the light of day in a courtroom because of how horrible it was. And finally, after 42 hours in the ED, she decompensates, gets admitted. And so her condition, she deteriorated in the ED to the point where she was intubated and admitted after 42 hours since her arrival. She had been admitted, meaning getting into the inpatient side, but she was laying in a hallway on a stretcher for that entire time period. And 2 days after this 42-hour period, she had her heart valve surgery and died 2 weeks later, or died a week later, 1 week later. So who's to know? Who knows if the outcome would have been different? But I think the family and others are legitimately asking the question. She should have received better care and a better chance at a better outcome, and that's enough to carry the day from a negligence standpoint.
And so much of the lawsuits are perception by the family as well, right? So even if this patient was getting good care in this hallway, and that was the best that the hospital could do given their conditions, it looks bad. They're like, look, mom's last time on this earth was pretty crappy. She was, no privacy, no rest. She's there in this hallway for 42 minutes. It was disgusting. Like, this isn't how mom should have been treated. Why didn't she have a room? Why did all of those questions? It just looks bad and it feels bad.
Yeah, no, you're right. And the family was there to witness it all. And it's hard to overcome that.
Where I think the facts speak for themselves, in that this lady wound up being intubated in the emergency department, and there had to be some gradual downhill slide in this case rather than some very abrupt kind of loss of the ability to ventilate. So I would be, if you put yourself in the position of this family, I don't think that they're kind of griping about small kinds of things. We're talking about 42 hours. In fact, one of the daughters asked to have her mother transferred to another hospital.
Yeah.
And she was told apparently by a nurse that, oh, she can't be transferred because she's admitted. And it was like, say what?
Yeah. Yeah.
I don't know that. I don't know that follows, but that's what she was told. So
Well,
they
it's
didn't pursue it.
complicated. It's complicated because under EMTALA, if you wanted to transfer the patient, that's one thing as an ED patient. Once they are admitted, even if they're sitting in the ED, the accepting facility is going to ask that question. If it's an inpatient transfer, they're not bound by EMTALA. So I get
Right.
it's more complicated, but you can call around, you can find another place. And this lady about to have most likely, if she ultimately did have a valve replacement, there's probably a place that would have accommodated her.
Yeah, I think this is a nice case of delay to start off our trilogy here. All right.
Yeah, that was a big delay. 42 hours.
All right, let's do amputations. Talk about a bad case.
Yeah, this is a really sad case. This is a 2-year-old girl who's brought into a Sacramento area hospital with a fever, weakness, and skin discoloration. I don't know what that means, but it doesn't
We're
sound.
going to find out.
But
Yes.
it doesn't sound good. Doesn't sound good. She was apparently triaged briefly and went to the waiting room, and her parents watched her get sicker and weaker. And after more than 5 hours, the father finally forced his way into the triage area and demanded help. The child was reassessed and apparently quickly found to be in a grave condition and was actually flown to Stanford for life-saving care because she had septicoccal septicemia. She had amputations of both feet, her left hand, and part of her right hand. This poor 2-year-old kid. The primary focus of the suit was delay in care. There was a $10 million settlement reached. One of the interesting things about this is when we look at triage, because that's where this delay happened. So in the JAMA Pediatrics issue in October of this year, they looked at a study looking at 21 Kaiser EDs between 2016 and 2022. And of that over 100,000 visits, they determined that about 58.5% were over triaged and only 7.4% were under triaged. But the problem was that most of those, or a lot of those under triaged, were kids under 6. And so I think that we do this a lot. We don't see a lot of gravely ill kids, at least in our emergency department. We see a lot of kids with cold and flu and RSV and COVID and all of these other things. And, the kid vomited once. And so the first time mom's bringing them in, whatever. It doesn't matter why we have these biases, but we are not great at triaging appropriately young kids with serious illness, in my opinion.
No, you're right. And I think part of that is, and tell me if you agree or disagree, both of you, but I think the natural progression of a disease course in an ill child is steady state and then precipitous decompensation. Comparatively with older individuals or adults, you can kind of see the steady decline before that precipitous decompensation happens. So there are some really sick kids among the other kids that all don't look well. Picking out the 1, 2, 3, or 5 among a big group that are really ready to decompensate is really not an easy task. And retrospectively, we look at it and say, "Oh my gosh, why didn't we see this one?" Because they were blending in.
Right. And I have to say, too, that it is not infrequent to get worried parents constantly coming up to the triage desk again and again on a busy night when you've got, sorry, Rick, but you've got waits of 4 hours. And if this kid was triaged as a level 4 They're not going to be at the front of that line anytime soon.
Close follow-up.
Yeah, I think that this was fundamentally a mistriage case where they're in the waiting room for more than 5 hours while this kid goes into septic shock kind of thing. And I think that the seriousness of this kid's condition was rapidly determined as they walked in. Dad brings the kid in and say, "Listen, you got to see this kid." And so I think there was no delay on once they got into ER, but this was a mistriage case. And although in this one study they were 1 in 14 of them were mistriage in terms of they were under triage, I think they found some interesting stuff. The fact is that mistriage is more common for children that were at least 6 years old compared with younger children. That's interesting. Male patients were mistriaged more frequently than females. Patients with Asian, Black, or Hispanic or other races or ethnicities were mistriaged more than whites. Patients with comorbid illnesses compared with those without were mistriaged, and patients who arrived by ambulance compared with those who were non-ambulatory patients. So this poor little kitty was clearly mistriaged, and it brings up the point that, ideally, who should do triage? Ideally, the triage should be done by the smartest doctor in the department, who knows a wide differential and basically is aware of the ability to connect dots between symptoms and say, oh no, this is one in 100 kids that we see that is sick. Because unfortunately, the vast majority of kids get well no matter what you do. Yeah, you think they get well because you gave them amoxicillin for their otitis or amoxicillin for their bronchitis, when in fact it had nothing to do with the recovery of these children. They get better no matter what, But there is this needle in the haystack phenomenon, and here was a great case of the needle in the haystack. And it's unlikely, frankly, that had this child been seen 5 hours earlier, that the outcome would have been any different. Once the skin changes are noted of DIC, the results are generally fatal. And that's been brought up before, because we had a case in our hospital where a college kid came this was over the Christmas holidays, and here in Pasadena, Christmas holidays are a big deal. We've got the Rose Parade, we've got all kinds of stuff going on, football games, jet flying over at the beginning of these events. And so the kid went to the local emergency department and was fever, myalgia kind of thing, and she was in her teens, and they said she had, the flu, because, it's kind of going around, quote unquote. And the next day, she came to our emergency department where she had a fever and was kind of looking kind of sick. And ultimately, she developed meningococcal septicemia, or she didn't develop it, she had it, and she died. And when our ER was named in the suit, the question was, when did you see the petechiae develop? Because once those are seen, you think you would have responded to the fact. And so it was interesting in that Dave Talon, who's our emergency department infectious disease specialist, said once and testified to this, once the skin discolorations and hemorrhages are noted, these are generally 100% fatal. So that's an aside. It's got nothing to do with this case, but I think that it's interesting in that it probably made no difference in the outcome of this case, number one. So I doubt I doubt that they're going to be able to show there was malpractice with regard to the medical care. There was certainly malpractice with regard to the delay of care, which ultimately you get into this question about ER docs owning the emergency department. Have you heard that said over and over? You got to own the
Mhm.
emergency department. Well, I think you do actually, because you're basically in charge of the medical care going on in the entire department, and that department includes the waiting department. That includes the people who are holding a bag and vomiting it into it. Uh, so I'm not sure how you're supposed to do that. You're supposed to trust the triage people, but there's all variety in terms of the skill level, and there's lots of articles that talk about mistriage. Yeah, we're okay if you over triage, but under triage, over triage was almost 60% in this study that was done, and that's using what they call ESI for ESI version 4. There's a version 5 out now, and I don't know whether it's any better or not.
Well,
But
you know what though, Rick? So there are a couple of things about this. One is, first of all, I do agree with you. You do have to know what's in the department. And one of the ways that you can quickly do that is just what is the complaint? What are the vital signs? Just looking, is there any red flag that you see? Are still relying on the triage nurse and that sort of thing. But in this case, they described the kid presenting with skin discoloration and
yes,
lethargic. Those two things right there with abnormal vital signs, that should have prompted probably a closer look. The other thing that I would say is very, very important and is a culture in our department is that first of all, we do put good people out in triage. But we also have an open door policy. Look, if you are concerned about any patient, you're worried about this patient, you want us to come out and look at them, or you have any questions, what do you think that this could be going on? Whatever. They've our triage nurses come to us pretty frequently with questions or, hey, can you just eyeball this person or whatever. I think that's a good policy to have.
I think you're right, Shannon. I would say too, terminology is important. If parents report the child as being weak, and I think weakness was a term used, well, what is your clinical assessment, triage nurse or triage physician or whoever else was out there? Because if you're saying the word lethargy, okay, that's different. If they're just
Yeah.
reporting, I think they're just a little less, they're a little less active. They're weak. What do you mean by weakness? But something that I can hang my hat on is you've got a child that that has a fever and has skin discoloration, fever and rash. I want to see that.
Yep.
Even if it's for a second, because what happened here is probably the point of no return with purpura fulminans and sepsis. And once it's very time sensitive. And once you enter into that cascade with purpura fulminans, we know that the mortality rate significantly goes up, but also the thrombotic event that goes along with all of that. That's when you're going to lose limbs.
Right.
yes, exactly. We didn't. I thank you for focusing on the etiology of this thing. These clots form, and they go to the distal organs. What are the distal organs here? The extremities, the fingers, and in this case, it was both hands. My goodness, can you imagine?
So an elderly person or an older person with comorbidity doesn't survive this, but the youth with sepsis, they do survive, but with incredible long-term morbidity and disfigurement and horrific outcomes.
Really sad.
Yeah. Okay, I was trying to think if there was any other thing in this case that I thought was important. But I may come back because I just lost my thought on something that was extraordinarily important, of course. Let's talk
Okay.
about the last case. The last case is this is a Chuck Pelcher case. He does a thing called Medical Malpractice Insight. It's a free newsletter that comes out every month. If you want to get a hold of it, just get it. It's Medical Malpractice Insights. Go onto the internet. Let Chuck know that you'd like to get it. He does a case or two every month. And I kind of feel that it's okay if we take his cases, if we can add something to the discussion of it. And so that's my justification, and I'm sticking by it, Chuck. Okay. So a 5-year-old boy seen by his primary care physician with abdominal pain, no bowel movement for 5 days. He has a history of recurrent constipation. He has minor abdominal distension and tenderness per his family doctor. Vital signs are normal. He's given his usual laxative treatment and sent home. The next day, the pain is worse. The article said this was 8 out of 10. I don't know how a 5-year-old does that. Maybe they do the faces thing. And there is still no bowel movement. He's brought to a critical access hospital. This is a hospital that has 25 beds or less. Pulse is 154, respiratory rate is 34, O2 sat 94. He appears non-toxic, according to the notes written by the person in the critical access place. His abdomen is soft, mildly tender, and distended with active bowel sounds and no masses. Rectal exam notes say large, firm fecal impaction. It's unable to be disimpacted. They give multiple trials like this, and it didn't work. The child vomits once in the emergency department, X-ray department, where they're doing a KUB, which shows a large amount of gas, stool, and colonic distension without obstruction or other pathology. Well, kid's white count is 19,086 PMNs. Glucose is 358, CO2 is 14. So subsequently, this was not known at the time, but a manual differential was done later, and he had 15% bands in the neutrophils. So a 50 ml bolus of normal saline is given, but before insulin is given to treat this DKA, a repeat glucose comes back at 148. So a surgeon is consulted about what to do with this situation. He said, do a gastrograph and CT enema. And a fist-sized impaction without perforation was noted. But that was noted on the plain X-ray. Pulse ranges from 150 to 170. Respirations are around 40 now. He continues to worsen. After 3.5 hours, transfers are arranged. And while awaiting transfer, he arrests and is unable to be resuscitated. The autopsy noted a dilated colon with dusky serosal surface, which I'm going to say is an ischemic surface, knowing what this is about in hindsight. Cause of death, sepsis peritonitis due to a large bowel obstruction due to a fecal impaction. And Chuck had brought out that this is, they had done a prior case about stercorol. We don't use that word a lot. Stercorol colitis, which is basically pressure in the bowel wall caused by these fecal impactions, causing ischemia and leakage of bacteria into the bloodstream. And that fecalomas can lead to local pressure, necrosis, and perforation, while colon distension and increased interluminal pressure can lead to compromise of the vascular supply and ischemic colitis as well. So this is in a this is a large article I found about this subject. It's in the National Library of Medicine's. They have a thing called Stat Pearls, July 10th, 2023. So, we kind of like, oh God, it's a fecal impaction, easy diagnosis. And then you ask some nurse to disimpact somebody, when in fact, my brother, of which I have a couple, one of their wives, a mother, died of a fecal impaction. She had extreme osteoporosis, was always in severe pain. There was nothing they could really do for this lady to help her except give her opiates. And you know what happened when she got onto the opiates. The opiates resulted in inability to have a bowel movement. The next thing she noted, she developed a fecal impaction. The next thing, she had a perforation, and she became septic and died. So this lady died of a fecal impaction, just like this kid died of a fecal impaction. So I think we need to put in our head that you got to be careful with these cases, because it makes a lot of sense. You've got like a rock down there, and there's pressure pushing it on that rock, and that bowel wall is basically becoming ischemic leaking E. coli into the bloodstream, gram-negative septicemia. And so certainly this was an unusual case, but it's our job to talk to about unusual cases. This kid had a 19,000 white count,
Yeah.
150 to 170 pulse. Come on, there's something sick about this kid.
No, you're right. And I think I agree with you. I think it's important for people to recognize that when there's a downstream effect of ischemia due to whatever bowel issue is going on, you can start to develop bacterial translocation then. That bacteria that's in the bowel can then easily get in the mucosal
Bacterial
surface and
translocation.
Mhm.
Translocation. I hadn't heard that
Bacterial
term.
translocation. It can then just move right in there and you get septic from it. The other piece too is I don't know this case, but in an adult, you've got fecal impaction and maybe a medication issue or something else going along with it, but maybe it could be a primary diagnosis. For me in peds, fecal impaction is never a primary diagnosis. I want to know why. I know that it may be on the outside limits of the age group, but this case is screaming aganglionic megacolon to me, Hirschsprung's disease. I mean,
that's a good point. That's a good point. It probably was irrelevant in the emergency department.
right.
This basically was this kid's final episode, and I think it's really unfortunate. People in the critical access hospitals, they basically don't have great backup. The idea of transferring people is always there, but is the weather okay? Can they be transferred? It's not easy business, and anything can walk in the door of a small emergency department. Anything. So
I think a weird KUB in a kid with a presentation like this. I'm sorry, I don't think he's going to the CT scanner.
Yeah, I can only try to put myself in the shoes of the treating physician, and one of the things that I think is a little bit unusual is when they did the exam, they noted the abdomen to be soft and only mildly and diffusely tender. Is that right?
yeah, yes, it is, and I can give you my 2 cents about that after you get done your comment.
No, but what I would say though is that the complaint, the vital signs, the white blood cell count, all of those things should be very concerning.
And that's what I was saying too, that, the surgeon comes to see him. Well, maybe we do need a study, but in the context of a heart rate of 154, rest rate of 34, there's still mild tenderness, but now the abdomen is really distended. This is not constipation then resulting in an impaction. Something bad's happening, and you probably need to go explore this and take a look.
This is a 5-year-old boy. A 5-year-old boy should not be walking around with 150 pulse.
No. And a distended abdomen.
And it's interesting too that they got diverted by the 358 glucose. And, with the 358 glucose and a CO2 of 14, that's the diagnosis. We got a case of DKA
sepsis
here.
Well, or this is stress response from the sepsis.
Right.
I think they basically reran the glucose because it was high, and they got a different number. So there was a little lab thing going on there.
Yeah.
Which kind of just, fuzzed up this case a little bit, but not fundamentally. Fundamentally, this kid was terribly sick, and there was ultimately a delay in his care. And this is another case. Kevin, you may be right that the prior diagnosis was Hirschsprung's megacolon. However, the idea of having that as a primary diagnosis would have been helpful. But remember Greg Henry, the biggest problem associated with the current diagnosis is a prior diagnosis. So the kid has a history of constipation. So, maybe it's just a constitutional kind of thing. Maybe it's not something because he's 5 years old. I don't know.
Well,
uh,
90% are diagnosed by 5 years old, but why does a kid have chronic constipation anyway? That's the way some
Well,
of these
that's-
kids present. And so I would
Mm.
just say, anytime you see an abdominal presentation like this in a kid, we should just be making sure that we're asking why and not just accepting, oh, constipation as a diagnosis, impaction as a
Okay.
diagnosis. No, why is a 5-year-old experiencing this? Because something bigger is probably going on.
Good to know. Okay, that's a wrap. This is the December issue of Risk Management Monthly. We'll talk with you in January. I hope you had a great holiday with regard to your family over Christmas. That's the time everybody's got to come together if you have family. And I appreciate both of you guys being with us for the last year. Thanks so much.